Hi, everyone. I'm very excited to be joined today by Becca, who is a neurodivergent therapist and supervisor. They very kindly offered to share some of their experiences and insight on neurodiversity affirming therapy. So, the first question is actually about self-disclosure in therapy with autistic individuals. Would you be willing to discuss a little bit about how some of the more traditional kind of blank slate approach can sometimes be less ideal or even cause harm with working with autistic individuals? And then, kind of on the flip side of that, is there a risk of going too far in the other direction and maybe potentially veering into excessive self-disclosure?
Yeah, absolutely. So, for those of you that don't know, um, the approach to being a therapist, particularly a longer time ago, was taught as be a blank slate. Don't share anything with your clients. Don't tell them about your life. Like, keep the focus on them all the time. And so that has sort of led to this idea that therapists aren't really people, or that you're talking to someone who doesn't really get anything in life because they're so stoic. And I think, especially for our autistic clients, having a blank slate therapist can feel like you're talking to someone who's just really fake. And because we can be so intuitive about the people around us, even if we can't put words to like why we have a feeling about something, it can really put a hindrance to like connecting with the person who's across from us. And research on effectiveness in therapy has really shown that the most important thing for therapy to be effective is the relationship between the therapist and the client, not the modality, not what you use, but who you are in that space and how much your clients feel like they can trust you. And if you're someone who's constantly deflecting what's happening, your client's not going to feel like they can trust you because they know that you're hiding something, even if it's just a personal detail. And that's not to knock the therapists who don't want to share too much about their personal lives. I think that there's totally a way that you can balance self disclosure and not being totally blank. And on the flip side, as you asked, sometimes there are therapists who disclose too much, and that might look like not checking with the client for consent before disclosure. So just sharing as though you'd be talking to a friend, which can lead to some role confusion. And it can also shift the focus because I know I work with a lot of hyper empathetic clients who part of the reason why they struggle is because they feel things so deeply. Although I work with alexithymic clients who don't feel things like that either. But I have clients who are concerned about the way that they share and process things might impact me, and they don't even know that much about me. So, if you tell your clients everything, if there's a lot of self disclosure, then they might um, start to worry about what they can share. This is my cat, Zoe. They might start to worry about what they can share, if they have to protect the therapist in the space. Or they might get re traumatized or triggered about their own stuff that comes up based on what their therapist shares or how their therapist shares. So I tend to lean into how much is actually important for my clients to know, how much needs to be said explicitly versus can just be modeled through like the way that I move in session. Um, and the thing to stay away from in terms of blank slate, I would say, is deflecting when someone asks something about you. Like, I know I was taught in grad school that if someone asks a question about my personal life, to ask them why it's important to them. And I just think it's so minimizing to have someone want to know, like, my cat's name or like who I live with or what I like to do for fun. And to be like, why does that matter? Instead of just being a person with them and telling them, which can be so connecting.
Absolutely. Yeah, thank you so much for that answer. And I think you addressed this a little bit already, but are there specific signs that you would suggest therapists to look for to maybe gauge after they've disclosed something, whether it's whether it was sort of well received or whether it maybe was too much for a client, or yeah, any other suggestions you have for how therapists can kind of tailor it, because I'm sure it's not a monolith for each patient, how they can kind of figure out in advance whether something would be in the benefit of the patient or maybe induce that kind of hyper empathy or need to take care of the therapist.
Yeah, there's absolutely signs, and also there's no way to get this perfect all the time. So I think part of good self-disclosure comes with the awareness that we're not always going to get it right because we're people too. And how can you repair or come back from it if you do cross a line that you didn't realize you were crossing? Because we are going to sometimes mess up in session or say the wrong thing or not respond, or our client responds in a way that we didn't anticipate. And sometimes that can actually be in service of the relationship because we can walk them through how to talk about that, where maybe they don't have anyone else in their life who they can talk about that with. And we can show them how to do it in a safe place. Some things that I tend to think about: if a client starts to seem disengaged, like they're not paying attention, or maybe like they're dissociated, which could, it's a little bit tricky to differentiate if you don't know the client because autistic folks aren't always looking at you. But sometimes like staring at a distance might get a glazy eye, a glazed look in their eye, really starting to feel either like they're checked out, is more, I think, how my autistic clients would probably tend to respond to over disclosure. Some clients might move to change the topic rapidly. I have some clients who are really direct and be like, I know that I don't need to disclose to them because they'll say, well, I don't really care. So I know that it means doesn't mean that they don't care about me, but they also know that that space is for them, and whatever I would have to say isn't relevant to them for that, which is totally fine. Not every client wants that, but other clients are like, "Hey, I don't know if I should ask you this, so could I?" Um, and I heard somewhere this was from an holistic therapist, but I found it to be a pretty good gauge that the spotlight in session should, there should be a 5 second rule. If the spotlight is on me for more than 5 seconds, then maybe it's time to shift back. So my clients could easily, some of them, ask about me, figure out what's going on in my life, want to talk about those things. And for some autistic clients, like therapy is the one space, if they have an affirming therapist, where they can just kind of have that discussion. And especially if they also have an autistic therapist and they don't have other spaces where they interact with other autistics, that might be like social hour for them. And so we have to balance the social aspect and the way that we care for our clients and they care for us with, okay, they have goals that they want to work on and a reason that they're here. And talking about myself may not be in service of that, right? So if the focus is on the therapist too much and the client has a hard time shifting it back, and even still, even when there's too much self disclosure in that, like I said, we can use that for repair. And even it can be informative to help us see, oh, this client really has a hard time staying present with what's coming up for them, but they're so good at being present with other people. How could this be in service to the work we're doing together? And it doesn't always have to mean, oh, I like just really messed up and there's no coming back from it. Like there are ways to come back from it, but the things I mainly stay away from too are like really significant trauma or details. Like they don't really need details. Like I might say, oh yeah, I had some things that made it so it took a long time for me to graduate school, right? But I don't need to give them the play by play of each thing that happened, right? So that can be a little tricky when you're also neurodivergent. But yeah, I think that those are the main signs: checking out, leaning too much into what you've shared and not bringing it back to them, or like directly telling you, like, I don't want to hear that.
Thank you so much. That's a really helpful answer. And yeah, I have a lot of respect for therapists in a way because it does seem like such a multivariable process and you're doing it all in real time. So yeah, it's really neat. One question that is kind of related but a bit more general is how can therapists create an environment where patients feel comfortable bringing up any kind of feedback on any topic, including feedback that maybe feels difficult for them to bring up or that they might be worried that it would come across as too critical?
So this starts from the very first client encounter, right? This starts from the moment that a client reaches out for services. This is from the very beginning. How are we interacting with them in that? When we talk to them on the phone or video, if you offer a consultation before you work with someone, how are you communicating with them your process, how you engage when there's tension? Some of that might not come up more explicitly until an intake appointment, but with an intake, I always try and create a space of saying, I'm open to feedback. Like, tell me, not everything works for every person. I won't take it personally. We're getting to know each other. So I think there's like a level of what you're saying explicitly, but there's also a piece of what you're doing just in the way that you act and interact with them. The explicit piece is really important, in particular for autistics, because we might not intuit beyond, oh, this person doesn't feel like someone I could bring something to, but we might not be able to point to why we feel that way. Might just know we feel that way. Um, or I feel anxious, or I get stomach ache, or you might not even have such a specific insight. It might just be more of a general feeling of disease, right? But when when we're also giving that implicit space of, okay, this is how I respond to the things that you say in session. Our clients, whether they know it or not, are testing us constantly, and they should, because not all therapists can create the safety that people need to be able to be a therapeutic space. So, this unintentional or unconscious testing often looks like giving a smaller piece of information to see how someone reacts before you give them a bigger piece of information. Totally reasonable. So part of us as therapists is, okay, how are you receiving those smaller bits of information? And also being attuned and aware of like the shifts that come up for our clients, right? Like our clients tend to engage with us in certain ways, and being able to notice when there's changes. I'm a fan of making things like said. I know some therapists are more quiet about that. But when I notice a pattern shift, I tend to point it out because I think it's only helpful if we can all look at it and talk about it. So I might say, oh, I've noticed that the way that you've been talking with me in sessions have changed in the past couple of weeks. Is that something you've noticed? And I kind of check in and create a space. But I also am not going to pressure someone to tell me something because they might not be ready, or they might need more information, or they might need to figure out what is actually bothering them or what they might actually want to say. So naming it and leaving an opening. And then if they say they don't know, or a lot of times my clients need like a few weeks to process the information, regardless of what the information is, I might ask if it's okay if I ask them again in a few weeks. And that way it sort of creates an opening. So the job isn't on the client to do that. And there's other ways too. I mean, there's feedback forms that you can send like after a session to kind of check in. Did you get what you needed today? Like, was there something you wanted that you didn't get? Which is just like a few yes or no questions that can help a therapist kind of check in on, am I having the same thoughts about what happened today as the client? Because a lot of times we walk away and I think a lot of therapists are just like, yes, this is what happened. And we don't actually know. So also creating those opportunities to ask, even if not for feedback about us, but how do you feel like therapy is going? We've been working together a month now. What's going on? Or is it okay if we check in every 3 months to see where we're moving towards your goals? Because I think a lot of therapists also put the expectation of knowing what to do and what they want and what comes next on the client without meaning to. And especially for like autistic clients, like a lot of my clients come in, they're like, am I doing therapy right? I don't really know how to do this. And so if the therapist is like, go, your turn, and the client's like, I don't know what to do, then we're kind of putting it on them in what I think is an effort to be collaborative in the process and client led, then becomes sort of pressure for the client to like figure out how to do it, instead of being more open to what the client might benefit from and then creating opportunities to check in and see if it's still working. But I think if you're asking for feedback, not just on you, but on the interventions that you're using, on the modality, on how often you're meeting, if you're checking in about that stuff at regular intervals anyway, then it sort of creates this opportunity to give feedback, and then it's on you to receive it. And if you have feelings about what they say, take it out and deal with it in like consultation or supervision afterwards, because we will have feelings that come up because we're people too.
Thank you so much. That's a great answer, and I think one point that you brought up that I appreciate. Well, I'm not a therapist myself, just as a researcher, there was a period where I wanted to really make sure that people knew I was open to feedback, but I think I overdid it a little bit, where maybe they felt pressure to get feedback. So I've been kind of trying to scale back. Yeah, I think the point you brought up about how feedback can sometimes turn into a form of another task for people to do is a great one. The next question I have kind of builds on what you said at the end of it, and um, are there kind of common challenges or maybe pitfalls that you see therapists run into when receiving feedback from patients, maybe especially if it is difficult feedback? And what suggestions do you have for avoiding these pitfalls? Or, when you're working with someone as a supervisor, how do you kind of help them through that?
Yeah, so we tend to see, because I work with complex trauma, so the folks that I'm giving consultation or supervision to tend to also be working with not just complex trauma, meaning not just one traumatic event, but usually a series of traumatic events, often starting in childhood and continuing into adulthood, though not necessarily, could just be a series of adulthood events or a series of childhood events. But particularly being neurodivergent, a lot of us experience that complex trauma just as a result of being undiagnosed, and the way that we sort of navigate the world without realizing this giant piece of why things are harder for us in certain ways and why things are different. So I think for therapists, there can be a sense that like this is really personal, especially if a client gives feedback that's really personal, like that they're disappointed in you or that you've let them down or what you said wasn't helpful. And therapists have something called countertransference that we can get, where the interaction and relationship we have with a client can bring up stuff from like our own histories, just like clients can get transference with us, where the relationship with us brings up stuff from their histories. Um, and so, one of the main things that I work with therapists and other like supervisees, consult people I do consults with, uh, is around like what comes up for them when something is happening with their clients, because I think we're not taught a lot about it. So this is one of the pitfalls that I see, is that in grad school we're told be mindful of transference and countertransference, but you're not really given a lot of training on like how to notice that or how to work through it, which is part of why that's one of my interest areas for professional development training, because I find the therapeutic relationship so fascinating. So part of it is that internal work, being able to do that internal work of like, what is my stuff? Because we all have stuff, whether you have a trauma history or not, you have stuff. You have the things that like poke at you in the most tender ways. And if you have therapists that aren't super aware of what those things are, if they come up in that relationship, we are going to have a hard time navigating it because it's also going to be a surprise. Um, and I also like to use a parts framework. I'm an IFS therapist, and so internal family systems, which uses the idea of non pathologizing these different aspects of ourselves and just noting that certain behaviors and ways of thinking are um, in service to how we move through life, and that we have some parts that can be pretty protective, and that might manifest as like a defensive part. Well, I only said that because you said this, or um, uh, a part that maybe shuts down and then starts to cut like cut off that maybe they were more human in the way that they shared and less of a blank slate, and that feedback made them retreat back to more of a blank slate, right? So there's the piece of how do you work through what came up for you when that feedback was given, but there's also the piece of how do you move through and repair in this relationship, knowing that this rupture happened, which honestly, this is the training I'm working on developing now, is on repairing ruptures in the therapeutic relationship. Sometimes the therapeutic relationship can be a bunch more strong after a rupture because our clients can see, oh, we can work through things. And that means that I can work through things in other areas of my life. So I think letting their countertransference show up in how they interact with the client in that moment is part of it. And then helping them to come back after that to name it. But even sometimes when you're not getting explicit feedback, I know I've had an interaction with a client where I had a part of me that was like very problem solver mode in that moment. And it wasn't really attuned to what the client was bringing to me. And this wasn't a new client. So I think that that was part of it. And because I do IFS and because I work on these things for myself, I started to notice in the moment that I was not being attuned to what this client needed. And so I work with the therapists I work with to start building that internal awareness of when it's happening in the moment, even before the feedback. And I owned it in the moment. I paused and I said, I'm realizing that I'm not really attuned to where you are right now. I'm really sorry. I just want you to know that that has nothing to do with you or what you're communicating. This was a thing that was coming up with one of my parts. I'm really sorry. I'm here. Let's redirect to where you were now. And I think, especially for autistics who are used to being assigned and assumed responsible for why something isn't working relationally, to be able to name this wasn't a you thing, this was a me thing, and I've adjusted it now and I'm here, can be not just healing for the relationship, but also for like their own wounds, the client wounds. So I work with the therapists around that stuff, like noticing what's coming up for you. How can you process it either in your own therapy or in consultation outside of session? And then how can you come back and repair a rupture and eventually get to the point where sometimes, maybe not all the time, but sometimes you notice it as it's happening.
Thank you very much. And that actually leads really well into the next question, which is, um, are there are there ways to kind of determine whether it's worth trying to repair a rupture and continuing with the therapy and whether it can kind of result in a more stable relationship in the end versus when maybe a rupture has been so big or indicates that maybe the therapist isn't well equipped to support the client at this time, and that it would be best to try and like just come to closure and then refer the patient to another clinician who might be a better fit.
This is not a simple answer, Sam. Um, the reason why this is not so simple, or one of the reasons, is because when we refer clients out, they carry that. And I'm not saying that we shouldn't refer out. Sometimes we do an intake and we think we know what's going on, and then there's all this other stuff, and we really aren't like trained in supporting them, and it really isn't something that we should ethically be doing. But we do have to weigh the ethics of the relationship that we're in with a client, and knowing that when we refer out, especially if you've been working with someone for a while, they bring that. Like, I've worked with multiple clients who come to me and say, I've been referred out so many times. Everyone said that like I was too complex, or that no one could, that they couldn't help me, or they weren't trained. And so then I've worked with these clients who carry the internal messaging of, I'm too complex, I can't be helped. And so my question for the therapists who might be watching is this something that you don't feel like can be repaired because you're uncomfy? Or is this something that you don't feel like could be repaired because the client's saying that? Because those are different things. And I ask my clients, well, I'd love to have a session and talk about what's happened, but you also have the determination to your own, to like decide your own care. And if you don't want to work together anymore, then I can give you some referrals. um, and I always offer a closing session, even if there's been a breach, even if we aren't going to work together anymore, because there's so many situations in life where there's an ending that we don't have any control over. And it, I know for me and like the clients I work with, autistic clients I work with, like that loop never closes because it's unfinished, which means that it's something that's going to keep coming up because it's not closed. So having an opportunity for the client to really like name what the experience was for them. Sometimes the client maybe said something hurtful to you, and maybe you want a chance to kind of in an appropriate way name, well, it was really hurtful that you said that to me. And I know that it was coming from a place of hurt yourself, but I just wanted to name that it didn't feel good, right? Being able to let people know how what they're saying and doing impacts you, and being able to also honor the work that you've done up until that point, because we can lose that when there's been a rupture. It can feel like all there's ever been is this rupture, and not, oh, we worked together for 2 years and we met all these goals and then there was a rupture. Right? The focus can shift. So I think it's important to try and honor what's been done beyond the rupture. So for therapists, I would ask, if it's a you thing and not a client thing, can you work through it on your own outside of the session? What would that look like? Or is it such a egregious breach or rupture that you don't feel like you could support the client in the ways that they need without your stuff coming up in it? And I would encourage those therapists to be really courageous in those moments, even though it's hard, and kind of name like that this is bringing stuff up for me, and like that's not on you. Again, because I think when we refer out, we should be really intentional about referring out, that people have already started to share their stories with us, even if it's just in an intake. That's 60 or 90 minutes where someone's telling you their story, telling you their history, and to then whether it's 5 sessions or 50 sessions, say, well, actually, I can't help you, can feel like a betrayal. So I'm not saying there's never a time to refer out. There's certainly times, but I do think people tend to lean into referring out just because something happened that they didn't feel great about instead of trying to figure out how to move through it. And of course, if there's like a breach of safety or something like that, then you have to do what you have to do for safety. But if it's just like an emotional wound, not to minimize emotional wounds, but I encourage therapists to see what they can do to move forward if clients want that and have it be collaborative.
Thank you so much. I appreciate that answer a lot. And something that I'm actually jumping back a few questions, but are there, I guess, potentially subtle signs that a therapist might benefit from supervision or ongoing training related to neurodiversity? Yeah.
Uh, I think we all need it. Even neurodivergent clients, therapists. There's no way to know everything. We do grad school for 2 years and we do continuing education, and the continuing education is ongoing for our license renewal. But there's new things that are being learned all of the time. I think now we're in this time where people are using neurodiversity, neurodivergence, neurodiverse interchangeably. And so my first thing is always how someone using the language, are they using it correctly? um, with the caveat being that even some of the literature and resources out there uses different language, so I don't expect someone to get it right every time. I'm sure I get it wrong sometimes too, but people that tend to be more involved and connected to the community, whether because they're a part of the community or they get consultation and training from the community, um, they tend to be more specific and precise with their language. So, a sign for me, using neurodivergent to mean ADHD or autistic, when neurodivergence is actually an umbrella term that encompasses basically anyone that would be seen in therapy or meet criteria for a diagnosis of any kind, falls under the neurodivergent umbrella. So if someone's using that language, then I would want them to even just get some training in the neurodiversity paradigm so they could learn about the differences. And then depending on who they're working with, right? Um, Using a lot of disordered language, I think, is another sign. So saying that they treat something that doesn't need to be treated, saying they treat ADHD, they treat autism, these are not things that need to be treated, they're neurotypes. So it doesn't mean that we can't make treatment goals around it. Like, I might want to better manage my executive functioning, which is a result of my neurotype, right? But that is very different than saying that you're treating ADHD. So, someone who's using sort of medical model language, treat, ASD, and again, this isn't a across the board because there's some clinicians who are autistic and use ASD as an acronym because other people use it, right? But I personally shy away from and don't tend to refer to people who use that sort of language because I don't know how they're going to approach neurodivergence in session. And for me, that's more important than than anything. Like, I want to make sure that you know what you're talking about. So the other thing is, how much do they know about co-occurrences? This is a little bit more advanced because there's a lot of them. And again, you can't know everything. But if someone just is looking at autism and thinks social cues, social skills, and they don't actually know that, and we could talk another time about the double empathy problem and like how we just have different socialization, but like not to tangent into that, but I just wanted to name it. But they might only think of that and they might not think of the fact that you might have a co-occurring chronic illness, you might have POTS, you might have Ehlers-Danlos, you might have OCD, like these things that tend to overlap really strongly. Like, I think if you work with a population, it's important to know what you're looking at. And if someone only knows one piece of it, then even if they're more competent to work with clients with that one piece, it still would be beneficial to get more training so that you know the other pieces because they all play together. They all feed into each other. And also, some of them can look like other things, right? One of the things I talk about sometimes is how depression and autistic burnout can look the same, and how harmful it can be if you're trying to treat depression that's actually autistic burnout, because what you need for autistic burnout is rest and rejuvenation. And with depression, we more lean into go and push yourself and go for a walk and go outside and do the thing, even though you don't feel like doing it, which can push someone into worse autistic burnout. So if someone isn't asking the differential questions to figure out what might actually be, and they're making an assumption about what they're seeing when it could be multiple things, that's a sign that they might need some additional training or might like some additional training, right? And also, I would say this isn't super subtle, but if you're seeing something happen a lot, that's a sign too. For me, I started working with autistics and I then am working with a lot of clients who I'm noticing have OCD. So, what does that mean for me? I should probably do more OCD training, right? Even though that was never a specialization of mine. And so, when you start to notice the pattern in the clients you're working with, and you feel like you're coming up against not fully knowing, that's a good sign to get more information. But I think everyone benefits from ongoing consultation, especially with people who have different lived experience. Like even me, as someone autistic and ADHD, I get training from people who are of the global majority because they have a different lived experience with being autistic ADHD than I do, right? Even being someone who thinks gender is weird and identifies as pretty agender, like I present as very femme. And so I get training and consultation from people who don't present as very binary in their presentation of gender expression. And I think kind of checking to see what your own identities and privileges are, and then getting some training, even with things you've lived experience with, just so you're checking the other experiences, the way that other people navigate these things with different marginalizations than you.
Yeah, thank you so much for that answer. The last question I have is, what advice do you have for autistic therapists or clinical students? I think we probably both agree that autistic therapists have so much to offer the field and also probably face a lot of barriers within the field. So if someone's kind of struggling with inaccessibility, do you have, yeah, advice for them?
Yeah, this is heartbreaking, honestly. Like I see it way too often. Our field is not set up for autistic therapists to thrive. I could say for therapists in general to thrive, but autistic therapists in particular, especially those of us that are hyper empathetic and feel and experience the things that our clients do as they're bringing them to us, right? Um, I think the biggest thing, and these things are not always feasible. So my big caveat is some of this requires like a level of privilege that a lot of us don't have. Um, Trying to find internship or placements that offer flexibility and that are also already like affirming in their approach, ideally that are run by people who are autistic or ADHD and maybe understand, because you both have the challenge of whether or not to disclose to an employer and also whether to ask for accommodations through an employer. But you also have to figure out what are the things that work for you. So I would say, how big of a caseload can you actually navigate? Because a lot of us can't do like a 25 to 30 clients a week caseload without hitting burnout. So how big of a caseload actually works for you? I would say, what are the hours of the day that you feel like you're the best? Like for me, as a perpetual night owl throughout my life, who then forced myself into the early morning box for capitalism. Now I am a person who I do better in the morning, and as the day goes on, I'm worse. And when people ask for afternoon appointments, I tell them that I don't feel right charging them because I'm not as good a therapist. So you think, okay, there's some therapists, some autistic therapists who are like, I'm great at like 7 p.m., 9 p.m. I'd rather do that. I'm like, I'd rather do an 8 a.m. session. Like, so figuring out like what's the time that works for you. A lot of therapy practices when you're first out of grad school want you to do at least 2 evenings a week, which was really hard for me. So getting creative if that doesn't work for you. Could I do 2 early mornings instead? Could I offer like a weekend instead? Some autistic therapists do better if they can have like a break in the week and maybe their weekend is like Wednesday, Thursday instead of Saturday, Sunday. So, kind of getting creative with what actually works for you. Part of this is finding the clients that excite you that you actually want to work with and not working with clients who you're not comfortable working with. Like, I know I worked in community mental health for a number of years out of grad school. For those of you that don't know, you see Medicaid and Medicare clients in the community, often going into their homes. So there was like a lot of driving too. And you just at first get assigned like whoever has been waiting for a therapist a while. And I was getting these like 5-year-olds on my caseload, and I was like, I'm not a play therapist. So it made me really anxious and feel like I was doing a disservice to these clients. And me, as someone who's just as sensitive, trying to like go and like change an entire system, which has been operating this way, was like devastating for me because I couldn't really do anything about it. So I think having a practice you work for that's aligned with your values, um, so you don't run into that push pull with your employer, finding a supervisor who gets you and can support you in a good way, even if that's outside of that practice. I know a lot of people, myself included, offer lower fee supervision for um, preliminary licensed folks so that it's more accessible because you don't make a lot when you first are out of grad school. And I would also say having other ways to get excited and have an output that are not just reliant on client engagement. Um, I knew when I opened my practice that I wanted to have other things that I did that fueled me that weren't just client work because I love my clients, but I don't want 45 of them. That's like too many. And so, in order to continue to be able to support them in the best way possible, having other things I do for me, I do graphic design stuff and creating like resources for clients and groups that I run. I do these consult groups with other clinicians. I offer professional development training. For me, this is my autistic dream because I get to read and research all the things that are interesting to me. And then I get to info dump them on people who want to hear in their training. And all of that stuff helps build me up so that I have more to give to my clients. So, really trying to figure out what your own needs are to be able to be not just short term, but longer term successful. And by successful, I mean find something that works for you in the field. I think a lot of the lack of accessibility comes from having supervisors and employers that don't really understand feedback. I received a lot in my employment situations was about being combative or aggressive when I just didn't understand like policy changes and I just wanted clarification. So inevitably, I think having my own practice, which was something that I was nervous about doing because of my executive functioning, was the best, most accessible move for me because then I'm in control of who I talk to, who my clients are, how much time I'm doing those things. But that isn't something that everyone can do. And it's also not something you can do right out of grad school. So I would also say, like, figuring out what kind of setting you want to be in, what works and what doesn't work for you, and adjusting it when you notice it, because usually by the time you notice it, you're like way past the point of discomfort. So and seeking support from other autistic therapists, because I do think we want to support each other. We know that there need to be more of us out there. And like whether that's like looking for a mentorship relationship or just looking for support navigating some of the ableism of the field, like I think it's important to not act or feel like it's just a you thing. Because I think sometimes people who are autistic therapists and leave the field leave because they feel like they're set up to fail and that it's partially because they just couldn't cut it. And it just is not true. But it's not easy to break into. It's not easy to maintain, especially after all of the academic requirements.
Absolutely. Yeah, thank you so much for that answer. It was really informative. And I feel like a lot of these components, like figuring out what times of day or times of week, or even structured how to partition the week and weekend work best for you, could probably be applied to some other areas of employment as well, to some extent. The last question is basically just, is there anything else you'd like to add that I've forgotten to ask about?
I mean, I think the only thing that I want to add is not backtracking. Trust your instinct. This is what I come back to a lot, that I think a lot of times we stay in a situation or we stay with a therapist or we stay with a client that isn't working because we don't know what isn't working and we just have a feeling. But I think especially for autistic people, generally we don't know what happened until later. So by the time we stop or slow down or question, it's already been happening for a while. Um, and I think sometimes we stay with a therapist or in a situation because we think it's the only one, or we just like it already know it. So even though it's not great, like we don't want to change it because change is hard and we don't know what the other one will be anyway. But it's okay to not have a full answer. You can change anyway. You don't need to be able to explain why it doesn't feel right. You don't need to be able to explain what isn't working. Just to know that it isn't, I think is enough. And to it can be a good way to come back and trust yourself more, which is especially important when you have a lifetime of being told that you can't actually really trust yourself. Um, there's people and resources out there, even if someone doesn't take like insurance or doesn't know your specific thing. They might know someone who does. Um, and I also want to say that it's okay to not know what you need. Um, that whether you're a therapist or a client, like you don't have to know right away, um, because some of that can come with time. And for the therapists, whether you're autistic or not, I would say there's no shame in not knowing. There is so much in the field, and we can't possibly know it all. Like, we really can't. There's so much that I don't know. And even the intersecting identities that I work with, I really have more specialization in one than like three or four other, right? Because there's too much information. So, no one will think less of you for asking for more information or asking for help. Like there's nothing wrong with like seeking consultation or training in something that you just want to learn more about. Like it doesn't mean that you're a bad clinician. It just means there's a lot out there.
Absolutely. Yeah, thank you so much, and thank you for your time and sharing your insights in the interview. I appreciate it a lot.
Thank you so much for having me.